Good morning to everybody. As I say, there's a very early talk, so I am trying to summarize what is the trend now in maternal fetal medicine and what we think that is the most important issue to discuss in order to ameliorate the maternal infant health for the future. I would say that there are three important premises that titrate the reason why we should move to the periconceptional period. First, because we can at least know much better and eventually modify the healthy lifestyle before conception of any couples, and especially we can educate the couple for the subsequent event. And finally, there are many possibilities nowadays compared to the past that in the periconceptional period we may, at least by some markers, find risk population that may be addressed now also with the preventive tools. I would like, however, to be cautious that this is a very sensitive period, so whatever we do in this period should be always balanced with a risk that anything we do may provoke also big damages. If we remember what happens with diltiazem or thalidomide, which were, at that time supposed to be the best preventive tool for abortion or for other things, and then they revert to be teratogenic later on, I think that we have a big responsibility to move and to pay attention to this period. Not only, but now we have another responsibility which is given by the fact that everything we do in the period of the 9 months in utero can affect not only the newborn and childhood life, but also later the adult life. It is very strange that we are born the day we have a birth, and we don't consider at all the month before. It's never considered that we live 9 months, which are much more important than the days we live after we are birthed. To give an example why I think that people now in the last 10 years have switched to much more attention to the periconceptional period is the example of folic acid. Although I must say that in many countries the folic acid, let's say, implementation is still at a very basic stage. Just to think that only 2 years ago, Brazil, which is a country with a very high incidence of, let's say, neurotuber defects, have implemented, for instance, the messages to all the doctors to give folic acid before pregnancy starts, because it's completely unuseful. I think that is the best example in which many of us started to think that it's much better to think at the periconceptional period. You know that this vitamin is a vitamin which plays a multifaceted role in the enzymatic activity which are controlling the embryo development, and we know that the synthetic form of folate, which is appunto folic acid, can be used as a supplement or fortified in many food and is in a stable form. But if you look at the development of neural tube defect, you understand that from conception to the beginning of neural tube defect formation, there is only 13, 14 days, which is even the time that a woman doesn't know to be pregnant, because the test usually is done a few days later. Now, if you think that you have to start folic acid at that time, it's completely unuseful. It doesn't do anything for neural tube defect, for the simple reason that in order to ameliorate the concentration of folic acid in red blood cells, which are the vector of the folic acid, you need to have at least 1 to 2 months to rise the level and to incorporate this vitamin in the red cells. You can see that and I just mentioned one recent Cochrane, the reduction of neurotube defects in patients which had been given folic acid before pregnancy, at least 2 months before, is dramatic, more than 70%. And I think there is no dispute that the strategy for prevention is now to give a nutritional guidance, food fortification, periconceptional supplementation, and that's been proposed also to give to the adolescent and reproductive age woman folic acid with contraceptive pills, although this has not met the enthusiasm of the company doing the contraceptive pills. In fact, I think that no pill has the folic acid incorporated in it. However, I think it is very important because if a woman stops the pill and remains pregnant, at least the level of folic acid are already on stage. The International Federation of Obstetrics and Gynecology already 2 years ago published a very strong recommendation advice to utilize the 400 micrograms of synthetic folic acid beginning at least 30 days before pregnancy, the target pregnancy, taking in consideration that it's completely unuseful to get more of this folic acid. Sometimes it's even counteracting. And we have only to increase this amount of 4 milligrams in a risky population, which is now represented mainly by patients who had a previous neural tube defect baby, or they have a family member with a neural tube defect, or are obese, more than 35 BMI. This is a condition by which folic acid should be incremented. But we have to consider that giving very high concentration of folic acid is being associated also to some problems like, for instance, increased risk of autism. So it's very, as usual, as for vitamin A, we have to be very careful to give the right dosage to the patient. Now, the key elements of periconceptional counseling are now summarized in the next slide, dealing with starting with the medical history, because we know now that we can identify diabetes prior to pregnancy, optimize the control, particularly looking at the glycosylated hemoglobin levels that should be taken less than 6, for instance, in order to have not an increase, because there is a linear increase of fetal malformation with the percentage of glycosylated hemoglobin. And of course, mainly if the patient have chronic disease, to change and to see if the therapy they are taking ongoing should be changed because is maybe a therapy which is contraindicated in pregnancy. Then, of course, very important is genetic history. To be a carrier screening is sometimes demanding a control that can be done even by some invasive procedures that we may have during pregnancy. I just mentioned some of these particular disease like Tay-Sachs or alpha-beta thalassemia, which are prevalent in some population, and their frequency is by far very, very important, more than 10% or even 40% in some population, and of course they need to be a thoughtful screening in the parents and then eventually a diagnostic approach for the fetus in the late first trimester. You know that in this we have done gigantic steps in the last few years. In the 70s, the only reason why we were looking to a patient for genetic problems were the age, okay, but you know that, for instance, looking to the trisomy 21, we can detect only the 30% of patients because, of course, the majority, then the absolute number of patients are less than 35 years old. Then there was the introduction of, let's say, less invasive tools like the nuclear translucency associated or not with the biochemical test. But I think all these have created, because of a high positive rate, the convenience of a subsequent visit, a subsequent invasive procedure, which have created safety concern. And nowadays the patients are looking to the new tools, which are called non-invasive prenatal testing, based on the utilization of cell-free DNA, fetal DNA in maternal blood. We know that this DNA probably is coming by majority from the trophoblast, so it's not representing per se 100% the fetus, so there are some limitations for mosaicisms and so on, but by far, if we look now at the possibility of this test compared to 30 years ago, you can see that at practically the end of the first trimester, like at 10 weeks, we can detect practically all the chromosomal disorders, at least aneuploidies, with a very, very low false positive rate, which probably reduce the intervention of prenatal diagnosis, invasive testing to almost nothing in a big, big population compared to what we have done so far. So we are marching in having this periconceptional period up to the first trimester Very important. And also, FIGO as well, in a specific study group, has endorsed the fact that first, maternal age should be not considered anymore a screening tool or, let's say, a cutoff to divide the population in risky or not risky population for any genetic disorder. And secondly, the clinical implementation of DNA, of course, with an appropriate private-public interaction, because now it's only private, but let's say public-private interaction can be the future in this area. And we see that many current professional guidelines from the society, like the International Society of Prenatal Diagnosis or American College of Medical Genetics, are pushing for the use of this test as a primary screening test in all pregnant women at already 10 weeks gestation. Another very important area is the reproductive history of a woman. Sometimes we are dividing those which are interested in the reproduction of the woman, like people that are looking to fertility, infertility and so on, and the maternal-fetal medicine specialists. There is not much communication. But we have to consider that particularly in some disease, it is important to have strategies, because, for instance, to know that that woman had a prior preterm birth is a very important tool to start now therapy that can prevent preterm birth at least by 50%. The strategy, for instance, and I open a parenthesis for the preterm birth prevention, are looking to the fact that that particular pregnancy may have a prior history of preterm birth or is a multiple pregnancy, and as has been suggested also yesterday by Professor Will, short cervical scan is not anymore done in the second trimester, but can be done also in the first trimester with almost the same possibility of having a very good sensitivity like the scan of the cervix in the second trimester. This, of course, imply that we should screen all the women for the length of a cervix, and this screening is now appropriate in the second trimester, but it will be soon in the first trimester. And according to the fact that we find a short cervix is now by definition less than 2.5 centimeters, we offer to this woman a vaginal progesterone macronized, because it is the only drug which has been found associated with a meaningful statistical reduction of preterm birth, at least by 50%. Cervical length, so, should be proposed as a screening tool, and nowadays many are doing or associating this to the anatomic scan done in the second trimester, but many are moving this at the end of the first trimester, as I said, and then they offer early. But in the case we know the patient, even before pregnancy, that she had a prior preterm birth, the use of progesterone should be started as soon as particularly pregnancy started. So, all these data that you can see in meta-analysis are in favor of utilizing natural progesterone for the short cervix. This in singleton pregnancy, and all the study comprising the big English study called Optimum, in which there were several kind of, let's say, kind of patient at risk. But if we split only those with the short cervix, they contribute to maintain a high significant rate of utilization of progesterone, and also the very recent meta-analysis, which is published 1 week ago, in which also in twins with the short cervix in the patient, we may favorably give progesterone because ameliorate by far the neonatal outcome, at least by diminishing 50% neonatal mortality and the major morbidity. And there are guidelines, of course, especially this one, latest from the European Society of Perinatal Medicine, which are coming out now in the Journal of Maternal-Fetal Neonatal Medicine, which are addressing this issue completely. But you know, the other interesting area of periconceptional intervention is the lifestyle of a woman. Let's call lifestyle. Whatever is nutrition, whatever is food, whatever is medication that the woman is taking, whatever is the attitude, drugs, smoking and so on, this should be addressed before the woman starts pregnancy. It's too late when we address already at the first trimester or the late first trimester when the woman comes with a positive test. We have to recommend exercise from the beginning. We have to address the risk of nutritional deficiency, particularly asking to a woman if it's a vegetarian, vegan, or so on. Now it's very fashion to be vegan and vegetarian, but we have to eventually give a supplement to this kind of woman. We forget about not only that anemia, iron deficient anemia, is the most frequent problem in any pregnancy, particularly if pregnancy is already with a short interval before after another pregnancy, but we have a deficiency in also vitamin D, which is very important, and other supplement or micronutrients that should be looked at. While we have to try to change some abuse that sometime in the lifestyle of women are thought to be, let's say, social or traditional, like drinking coffee too much or drinking coffee, Coke and tea, because altogether caffeine is not a very good tool, a good nutritional tool in pregnancy, but is a tool which has been associated with an increased risk of preterm birth. Another important area, as I said before, is the interaction with people which are interested in reproduction and fertility. There are, of course, nowadays paid much more attention to what we call the polycystic ovary syndrome, although it's still a very debatable diagnosis, or the endometriosis. Because nowadays we know that these patients have various risks to have an increase, for instance, risk of gestational diabetes, pregnancy-induced hypertension, and also preterm birth, particularly polycystic ovary syndrome. There is probably an explanation to all of these, insulin resistance which is increased, inflammatory status background which is increased, and there are major risk of preterm birth, as well as endometriosis. In endometriosis, the risk is probably associated by an increased production of a specific cytokine and imbalance of lipid metabolism, which is particularly altered in the endometriosis patient. Then, of course, all the immunization infection. This is something that we should know before. There are some patients that arrive at the beginning of pregnancy which don't know their immunization status. They may be at risk to get an infection, and viral infection like cytomegalovirus, or a protoplasmic infection like toxoplasmosis. And of course, we suggest also dental examination. See that if we have at least a periodontitis, that patient has much more risk to have, for instance, a shortened pregnancy, even though the classification of periodontitis varies from let's say, overseas. The American classify periodontitis in a way, the European in another way, but there are consistent studies that, show that, for instance, periodontitis is something that we have to look in the patient in order. So a visit, at least during the periconceptional period, is welcome in order to avoid that there are these problems. You know that the screening for infectious disease is particularly important because many of these may affect pregnancy, create big problems, and create the problems how to solve the problem, because not yet for many we have either a vaccination or either treatment in pregnancy if, for instance, just to give an example, cytomegalovirus is showing a seroconversion during pregnancy. We know the most common, for instance, congenital infection is from cytomegalovirus, at least in our setting. We cannot say in Africa, but at least in Europe and North America, by far. And every hour in the world, a child becomes permanently disabled because of congenital cytomegalovirus infection. And I think that for a term baby, or toward term baby, is the major reason for cerebral palsy. So it's something that we probably sometimes forget. Unfortunately, all these things, which are very important, can be prevented either by giving a proper education to the patient in the periconceptional period, particularly in the second pregnancy more than the first pregnancy, because when the mother has already a little child, this child is sometimes the vector of the cytomegalovirus infection in the family, and secondly because, of course, it is by far the infection which more than any other congenital malformation is bringing problems of mental retardation, hearing impairment, and so on in young children. And we forget this. And now we have a study which has been very controversial in showing that for giving hyperimmunoglobulin against the cytomegalovirus, we can avoid major problems in the fetus newborn. Some other studies have shown that this doesn't work, but still we are going on. And you know that the way to the vaccination is still a little bit far away. Finally, I think that also the male should be looked at in this, let's say, periconception evaluation, particularly if there is an association, because some bad behavior of the male partner to the risk of, for instance, chromosomal abnormalities or vector of potential environment harmful exposure. In the setting of the environment, I would like to set this which is one of a statement FIGO has done in looking to the possibility to make awareness to the gynecologists around the world of the effect of environment climate on the reproduction, particularly beginning. Especially now that we have all this problem of migration. You see that migration and movement bring changes in the risk population. There is a lot of expanding vectors which are going from one continent to the other. Just think of what happens with the Zika. The increased environmental temperatures are associated with decreased fetal weight, so there is a small for gestational age increasing. Reports of gestational hypertension are related to drinking water salinity and prolonged dry season. There is more gender-based violence with the disaster, particularly if we have an earthquake or other disaster in the world. And, of course, we have to look at the pollutants, particularly what we call the endocrine disruptors and so on, because now it has been found, for instance, that the amount of mercury of people that in pregnancy are used to have, for instance, food like sushi is 50 times higher, okay, of the cut-offs levels. So people, women, which are used to get sushi, should be aware that it's better not to get the sushi in pregnancy because the mercury level became so high. And mercury goes to the fetus and remains on the fetus for years, okay, maybe changing by epigenetics the outcome future. I would like to say also that we are not, except for folic acid, so good to start periconceptional, let's say, treatment to avoid something. At least to given the lifestyle change in nutrition, we can do, decrease the risk of obesity, for getting this patient. But we have some early intervention which are particularly important. Early intervention means that should be started within the first trimester. For instance, when we are giving aspirin, okay, for now, a recent study in 3,500 patients, without any controversy, saying that aspirin is preventing from subsequent preeclampsia, gestational hypertension, and even preterm birth, okay? This should be started before 16 weeks, and it has been found that you can get 85% of success if you start before 12 weeks. So it's quite clear that you cannot start these things at mid-gestation, because it's too late, it doesn't make too much sense. So giving 100 milligrams of aspirin, given by evening, okay, only, because aspirin works only if given by night and not by day, and it's quite clear. FIGO has stated very well. There are some studies very interesting to show that the effect of aspirin is when aspirin is taken in the evening and not when it's taken in the morning. Okay, you see that FIGO good practice advice, which are released now, show that screening of first trimester for women at risk of gestational hypertension or preeclampsia. We can add the Doppler study, but still should be evaluated. Biomarkers are still going on, but the low dose aspirin has been found to reduce the risk by far. A woman should offer between 75 to 150 milligrams. The average is 100. Women should be advised to take aspirin in the evening because evidence support better efficacy during this time, and so on. So now these are simple messages that we should know before the pregnancy starts. And there is another comers that I want to speak at the very last minute to give you some insight of what is coming up, because there are a lot of new things. When our conception started not to look only to labor and delivery, but also to the early pregnancy, periconception, now many things are coming up that are interesting. Another interesting molecule is inositols. Inositols, is a sort of sugar, a polyalcohol, 6-carbon cyclic polyalcohol, and is very abundant in nature. There are many stereoisomers, and the most important is that it is a signal transduction substance which is implicated in the insulin action. And particularly, it has been found that patients or people that were using inositol have a much less insulin resistance compared to those which are not fed with inositol. This in animal study, but also the two stereoisomers which are present in our body with the chiroinositol or myoinositol, which are in a ratio between myoinositol 40 and chiroinositol 2, ratio 40 to 2, are being found to be very important in decreasing or ameliorating at least the performance, fertility performance of patients with polycystic ovary syndrome, because the action of this drug, which has no side effects by the way, and is very cheap also, is to interact with insulin sensitivity. You see that the binding between insulin and the receptors is mediated by some substances which are, the second messenger, the phosphoglycans, and these are under the control, for instance, of myoinositol. So we can reduce, giving myoinositol each day, between 2 to 4 milligrams, the insulin resistance by 70%. You can consider that just this, without any side effects, is something that we can give to any patient which is overweight, obese, or have gestational diabetes, or have, a very high risk of gestational diabetes, to decrease the risk of gestational diabetes. This is true. Yes, there are 4 or 5 randomized controlled trials, mainly done in Italy, one only outside Italy, which have shown that there is a reduced incidence of gestational diabetes in patients which have been taking myoinositol from the beginning of pregnancy, as you can see here. There is a reduced incidence in the population at more risk, so those with a BMI over 30. There is a decreased glycemic level, fasting glycemic level in patients which are taking myoinositol in pregnancy, and there is less complication due to GDM. In any case, even GDM comes up, there are much less complication, particularly those which are related, to, the birth weight, macrosomia, and so on. So in any case, even though the patient has a high risk because of GDM, giving myoinositol, we have a less macrosomia and so on. So I think that this is one possibility. The second is the entrance of probiotics. You know that we are a combination of microbiome and genome, human genome. Probably we have much more microbes in our body than cells which are of our property, and I think that it's been shown that probiotics regulate glucose metabolism, and this glucose metabolism is probably attributable to the immunoregulatory properties that a good balance of the microbiome in gastrointestinal tract is given. It has been shown now in a couple of studies that an active dialogue between host and microbiota in glucose metabolism is favorable, giving probiotics to ameliorate the glucose balance. Finally, antioxidant is the last part. Very simple. We have an increased oxidative stress in many pregnancies which are coming to be, affected by any gestational hypertension whatsoever. One of the ways is to increase the antioxidant defense and give antioxidant supplementation. The best probably is to feed the patient with chocolate cocoa, okay? Because it has been found that the antioxidant properties of cocoa are the highest in nature, okay? So particularly the components of flavonoids in the cocoa and their effect on the insulin response, on the blood pressure and so on, have been found either in the adult, either in pregnancy, to be favorable to increase the antioxidant properties and to decrease the oxidative stress. This is a study in adult human, and this is a study in pregnancy which are bringing this. Even though we don't have all the clinical evidence, I think the conclusion is that we have to move to the periconceptional period, as I said before, so look at the beginning of pregnancy up to the first trimester. Reframing the pregnancy care in the way I say, reproductive history, environmental toxic chemical, giving folic acid before, review genetic history, antioxidant oxidative stress, medical persisting contamination, and evaluate immunization and infection. We need to move to this period, move the early diagnosis in first trimester, adopt preventive periconceptional strategies, and continue to audit and follow up to have evidence of this, because evidence is still not heavy. I would like to finish with a sentence which I take from an economist who said once, in every forest, every farm, every garden on the planet, what is under the ground creates what is above. That is why focusing on the ripe fruit is useless. Those already on the trees we cannot change. but we can change from the roots the fate of our pregnancy. Thank you very much for